Good morning. Thank you, Dr. Wharton. I love that we're right on time. And welcome, everyone. This is Grace Lee, Chair of the Advisory Committee on Immunization Practices. Today is February 23rd, 2022, and I'm pleased to call today's ACIP meeting to order. I will turn it over to Dr. Melinda Wharton to share today's announcements.
Thank you, Dr. Lee. Good morning and welcome to the February 23rd and 24th virtual ACIP meeting. Next slide, please. Copies of the slides being presented at today's meeting are available on the ACIP website. Additionally, slides are available through a share file link for ACIP voting, liaison, and ex officio members. A few notes on meeting logistics for those who are listening in on the Zoom line. Please mute your lines at all times until you're called on for discussion. When Dr. Lee opens the meeting for discussion, please use the raise hand function in Zoom to virtually raise your hand. During the discussion period, Dr. Lee will take questions first from voting ACIP members and then from ex officio members and liaison representatives. Please disable your video until it comes time to vote, and then please turn on your video during the votes. Next slide, please. The Advisory Committee on Immunization Practices is, at its heart, a public body. Engagement with the public and transparency in our processes is vital to the committee's work. For this meeting, we will be holding one oral public comment period today at approximately 2:55 p.m. Eastern Standard Time. To create a fairer and more efficient process for requesting to make an oral comment, we ask that people interested in making a comment submit a request online in advance of the meeting. Priority is given to these advance requests, and if more people request to speak than we have time for, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2022-0022. Information on the written public comment process, as well as information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forgo participation in certain activities related to vaccines during their tenure on the committee. For other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but those members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains from all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next slide, please. I'm pleased to share the news that we're soliciting applications and nominations for candidates to fill upcoming vacancies on the Advisory Committee on Immunization Practices. Detailed instructions for submission of names of potential candidates to serve as ACIP members are now available on the ACIP website. Applications for ACIP membership are due no later than July 1st, 2022 for the 4-year term beginning July 2023. I will now turn the virtual podium back over to Dr. Lee. Thank you.
Thank you, Dr. Wharton. We will begin today with the roll call for ACIP members. I will ask that you state your name, affiliation, and whether you have any conflicts of interest. Today, we will start with Dr. Alt.
My name is Kevin Alt, and I'm a professor of obstetrics gynecology at the University of Kansas Medical Center in Kansas City, Kansas, and I have no conflicts.
Thank you. Ms. Bata.
Morning, this is Liz Bata. I am immunization program at the Minnesota Department of Health. I have no conflicts.
Thank you. Dr. Bell.
I am Beth Bell. I'm a clinical professor in the Department of Global Health at the University of Washington, and I have no conflicts.
Thank you. I'm going to move to Dr. Chen.
Wilbur Chen, Professor of Medicine at the University of Maryland School of Medicine's Center for Vaccine Development and Global Health. My employing institution, the University of Maryland, received a grant from Emergent Biosolutions that supported work I conducted to develop a Shigella vaccine. This does constitute a conflict of interest on decisions regarding the cholera vaccine recommendations and discussions today. I will not vote on the cholera vaccine. Thank you.
Thank you, Dr. Chen. Dr. Saneas. Dr. Saneas, you're still muted. Why don't we come back? Dr. Daly.
Good morning, Matt Daly. I'm a senior investigator at the Institute for Health Research at Kaiser Permanente, Colorado, also an associate professor at the University of Colorado School of Medicine, and I have no conflicts. Thanks.
Thank you. Dr. Cotton.
Good morning, Dr. Camille Cotton. I am the clinical director of transplant and immunocompromised host infectious diseases at Massachusetts General Hospital and associate professor at Harvard Medical School. No conflicts.
Thank you. Dr. Lair.
Dr. Jamie Lair. I am the owner of Cougar Family Medicine, a private family practice in Ithaca, New York. I have no conflicts.
Thank you. Dr. Long.
Good morning. I'm Sarah Long. I'm professor of pediatrics and pediatric infectious diseases at Drexel University College of Medicine. I have no conflict.
Thank you. Dr. Brooks.
All right, Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation. I have no conflicts. And good morning.
Good morning. Thank you. Ms. McNally.
Good morning, Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Paling.
Good morning. It's Kathy Palin. I'm professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflict. Thank you.
Thank you. Dr. Sanchez.
Morning. I'm Pablo Sanchez. I'm a professor of pediatrics at the Ohio State University College of Medicine. I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's, and I have no conflict. Thank you.
Thank you. Dr. Talbot.
Good morning. I'm Dr. Kip Talbot. I'm an infectious disease physician at Vanderbilt University Medical Center. I'm an associate professor, and I have no conflict. Thanks.
Thank you. Dr. Saneas.
Good morning. I'm Dr. Sybil Saneas. I'm an internist and pediatrician, associate professor of medicine and pediatrics, Warren Alpert Medical School of Brown University, and I have no conflict.
Thank you, Dr. Saneas. And this is Grace Lee. I'm a professor of pediatrics at Stanford University School of Medicine and associate chief medical officer for Stanford Children's Health, and I have no conflicts. So we are able to proceed, and our full committee is present. For our ex officio and liaisons, I will announce the organization name, and then please indicate if you're present and your first and last name. We'll start with the Centers for Disease Control and Prevention.
Good morning, Sam Posner, NCIRD.
Thank you, Dr. Posner. We'll move to Center for Medicare and Medicaid Services.
Good morning, Mary Beth Hans, present.
Thank you. Health Resources and Services Administration.
Good morning. This is Mary Rubin, present.
Thank you. Indian Health Service.
Good morning. This is Dr. Matthew Clark with the Indian Health Service, present.
Thank you. National Institutes of Health.
Yeah, good morning. John Weigel from the National Institute of Allergy and Infectious Disease, representing the NIH.
Thank you. Good morning. Office of Infectious Disease and HIV/AIDS Policy.
Good morning. David Kim, present.
Morning. Thank you. Next, we'll move on to our liaison representatives, the American Academy of Family Physicians. We'll move on to the American Academy of Pediatrics. All right, we'll come back. American Academy of Physician Assistants.
Good morning. This is Marie-Michelle Leger from the American Academy of Physician Associates.
Good morning. Thank you. American College Health Association.
Good morning. This is Sharon McMullen, and logging in for Dr. Tavi Chai from the American College Health Association.
Thank you. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists.
This is Dr. Linda Eckert, present.
Thank you. American College of Physicians.
Dr. Jason Goldman, present.
Thank you. American Geriatric Society.
This is Ken Schmader for AGS, present.
Thank you. America's Health Insurance Plans.
This is Bob Gluckman, present.
Thank you. American Immunization Registry Association.
Good morning, Rebecca Coyle, representing ERA.
Good morning. American Medical Association.
Sandra Freihofer, Adjunct Associate Professor of Medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
This is Chad Riddle, as liaison for the American Nurses Association.
Thank you. American Osteopathic Association.
This is Scott Cyrus, standing in for Dr. Stan Grog for the American Osteopathic Association. Good morning, everyone.
Good morning and welcome. American Pharmacists Association.
Good morning. This is Steve Foster filling in for Michael Hogue for the American Pharmacists Association.
Thank you. Association of Immunization Managers.
Hi, good morning. This is Molly Howell representing AIMS.
Thank you. Sorry. I need more coffee. Association for Prevention, Teaching, and Research.
Richard Zimmerman, University of Pittsburgh for APTR, present.
Thank you. Association of State and Territorial Health Officials. Next, we'll move on to Biotechnology Innovation Organization.
Good morning. Phyllis Arthur on behalf of BIO.
Good morning. Council of State and Territorial Epidemiologists.
Christine Hahn, present.
Thank you. Canadian National Advisory Committee on Immunization. We'll move on to Infectious Diseases Society of America.
Earl Baker, present.
Thank you. International Society for Travel Medicine.
Elizabeth Barnett here for ISTM.
Thank you. National Association of County and City Health Officials.
Good morning. This is Matt Zahn, representing NACHO, present.
Thank you. National Association of Pediatric Nurse Practitioners.
Good morning. Patsy Stinchfield, present.
Thank you. National Foundation for Infectious Diseases.
Good morning. This is Bill Schaffner on behalf of the NFID and also logging in for Marla Dalton.
Good morning. National Medical Association.
Good morning. This is Dr. Dio Hewlett, National Medical Association, logging in on behalf of Dr. Patricia Whitley Williams.
Thank you. And welcome. Pediatric Infectious Disease Society.
Good morning. Sorry, I had trouble unmuting. Sean O'Leary, representing PIDS.
Thanks, Dr. O'Leary. Just a minute of time. Pharmaceutical Research and Manufacturers of America.
Corey Robertson, present. Good morning.
Thank you. Good morning. Society for Adolescent Health and Medicine.
Good morning. It's Amy Middleman for SAM.
Thank you. Society for Healthcare Epidemiology of America. Okay. Thank you. Are there any ex officio members that have joined that wish to announce themselves? Are there any liaison members that have joined that would like to announce themselves?
Dr. Lee, this is David Kimberlin, AAP Red Book editor.
Thank you, Dr. Kimberlin, and welcome. Anyone else?
Dr. Lee, this is Dr. Rockwell. I'm not sure you heard me the first time for AASP.
Thank you, Dr. Rockwell. I did not hear you the first time, so welcome.
This is Dr. Marcy Dries representing Shea. Thank you.
Oh, wonderful. Thank you. Yes, sorry, I moved the roll call quickly, so you have to unmute fast. Anyone else? Okay, excellent. We don't have any additional opening remarks today, so I think we are ready, Dr. Wharton, to move on to the first session for the day. We'll start with Dr. Kathy Paling, who is chair of the TBE Vaccines Work Group, who will provide an introduction and overview of today's session. Dr. Paling, the floor is yours.
Wonderful. Thank you. All right. So on behalf of the Tickborne Encephalitis Vaccine Work Group, I want to introduce this section. Next slide, please. First is the background. The FDA approved a TBE vaccine in names. It's Pfizer Tickborne in August 2021. No TBE vaccine has been previously licensed in the United States. As such, there's no existing ACIP TBE vaccine recommendation. As a reminder, the TBE vaccine work group was formed in September 2020 to discuss use of TBE vaccine in U.S. persons traveling abroad and laboratory workers. Next slide, please. I want to take a moment to thank all the members of the TBE vaccine work group who have contributed greatly to these discussions and the recommendation. The ACIP members, including Wilbur Chen, ACIP liaisons, ex officio members, technical advisors, and CDC participants. And a special thanks to our CDC lead, Dr. Susan Hills. Next slide, please. As a reminder, we have previously presented to the ACIP in October 2020 a background on TBE disease and vaccines and a summary of Pfizer's TBE vaccine. In February 2021, we presented the TBE epidemiology in endemic areas and TBE among U.S. travelers and laboratory workers. In September 2021, we presented immunogenicity and safety of Pfizer's TBE vaccine. And then in January 2022, we presented evidence to recommendations framework. Next slide, please. So today, we are hoping to wrap up this session and took seriously the recommendations to focus on considerations on how to recommend a traveler's vaccine. So we will start with a brief review of TBE and TBE vaccine, and then focus on review of considerations for use of TBE vaccine and proposed recommendations for laboratory workers, and then a review of considerations for use of TBE vaccine and proposed recommendations for persons who travel abroad. Next slide, please. So thank you. Over to you, Dr. Hill.
Thank you very much, Dr. Paling, and good morning. Following presentation of the evidence to recommendations frameworks for TBE vaccine at the recent ACIP meeting, the work group has discussed our recommendations in light of ACIP members' feedback, in particular on the categories of recommended and shared clinical decision-making in the context of travel vaccines, and also providing the best clarity on who might benefit from vaccination, given this vaccine is more likely to be given by general healthcare providers rather than specialist travel medicine providers. Today, on behalf of the work group, I'd like to present our revised recommendations for ACIP members' consideration. I would like to ask ACIP for 3 votes. The first will be the recommendation for laboratory workers. The second and third votes will be for our revised recommendations for persons who travel abroad. These recommendations have a recommended component and a shared clinical decision-making component. We would like to ask for separate votes on each component of these traveller recommendations. After the previous meeting, members of the 2 ACIP work groups with proposed travel vaccine recommendations discussed categories with the ACIP Secretariat and received the following guidance. For the recommended category, the vaccine should be recommended if there is any group of people who should receive the vaccine. That is, the benefits of receiving the vaccine clearly outweigh the risks. The shared clinical decision-making category is appropriate for use if no group for whom the vaccine should be recommended can be identified, but some individuals might reasonably choose vaccination and some providers might reasonably wish to recommend it for some travellers, or if there are any groups of people where the benefits of receiving the vaccine might not outweigh the risks, so there is uncertainty. In both categories, the risk-benefit consideration for vaccination should weigh factors such as the likelihood of exposure based on location, season, time and activities, the risk of disease and its potential severity, the vaccine's efficacy, and the possibility of serious vaccine-associated adverse events. The Secretariat further clarified that travel vaccines often require consultation with a healthcare provider to identify which, if any, are indicated based on the traveller's age, travel plans including destinations, duration and activities, and other risk factors, and this is not shared clinical decision-making. Before presenting the considerations that went into developing our proposed TBE vaccine recommendations, I would like to provide a very brief review of TBE and TBE vaccine. TBE virus is a flavivirus related to Powassan virus. There are 3 main subtypes of TBE virus which differ in their geographic distribution and in the severity of the disease they cause. TBE virus is primarily transmitted by infected Ixodes species ticks, and infections are usually acquired in wooded or surrounding areas during recreational activities such as camping, hiking, fishing or hunting, or by persons involved in outdoor occupations such as the forestry service or farming. TBE is focally endemic in parts of Europe and Asia. Approximately 5,000 to 10,000 TBE cases are reported annually from endemic areas, and incidence is variable from country to country, in areas within countries, and from year to year. The main risk period occurs in the warmer months from April through November when ticks are most active. Among US persons, there have been a very low number of TBE cases, with only 20 cases diagnosed in the 20-year period through 2020, 11 among civilian travellers and 9 among military personnel. However, when neuroinvasive disease occurs, it can have potentially high fatality and sequelae rates. The TBE vaccine, manufactured by Pfizer as Ticovac, was approved last year for use in persons 1 year of age and older. Although only recently licensed in the US, the current formulation of the vaccine has been available internationally for more than 20 years, and more than 75 million doses have been administered. It is currently marketed in about 30 countries, primarily in Europe. Based on the grade assessment conducted by the ACIP TBE vaccine workgroup, immunogenicity results showed that seropositivity rates after the primary series were high, over 95% in most studies, and rates were also high after a booster dose. One limitation in this assessment was that the vaccine is based on a European subtype TBE virus, and there is likely but unconfirmed protection against non-European TBE virus subtypes. In terms of safety, vaccine-related serious adverse events were rarely reported. I will now provide the key considerations for vaccine use in laboratory workers working with TBE virus and discuss the proposed recommendations. Several key factors were considered by the workgroup. Firstly, TBE virus transmission has been documented in the laboratory through virus aerosolization, and transmission through accidental percutaneous or mucosal exposures is possible. Altogether, more than 46 laboratory-acquired TBE virus infections have been reported globally. Currently, fewer than 10 laboratories in the United States work with TBE virus for diagnostic or research purposes, so there are a limited number of staff who will require vaccination. TBE vaccination will reduce laboratorians' risk of a potentially very severe disease. And finally, vaccination is feasible as it can likely be implemented through existing occupational health programs. When considering all the domains of the evidence to recommendations framework for laboratory workers, the workgroup determined that the desirable consequences of vaccination clearly outweigh the undesirable consequences in most settings. And our proposed recommendation for ACIP members' consideration is TBE vaccination is recommended for laboratory workers with a potential for exposure to TBE virus. Now I will discuss the key considerations and our proposed recommendations for persons who travel abroad. The work group started by asking, is there a group of people who should receive the vaccine? Or in other words, is there a group where the benefits of receiving the vaccine clearly outweigh the risks? The key factors we considered were the overall risk of disease for a traveller, the potential severity of disease, patterns of disease transmission, risk factors for disease among US travellers, tick-related factors, vaccine recommendations in endemic countries, and vaccine-related factors. I'm going to briefly discuss each of these factors. Firstly, in regards to the overall risk of disease for US civilian travellers, TBE is clearly a very rare disease, with only 11 cases diagnosed during the past 20 years, or about 1 TBE case diagnosed every 2 years. Based on numbers of US travellers, the risk for all US travellers to TBE endemic countries is less than 1 TBE case per 30 million trips. To understand risk among a more select group of travellers, we consider just those travellers who might visit specific risk areas within endemic countries, travel during the main transmission season, and undertake activities with risk of tick exposure. In this specific group, the risk estimate was 1 TBE case per 2 million trips. Because of potential inaccuracies in assumptions required for the calculation and possible underdiagnosis of TBE or other factors, the risk range could be from 0.1 case to 5 cases per million trips. While TBE case numbers are low, potential severity of illness for patients with neuroinvasive disease must be considered. Most persons will require hospitalisation and there is no specific antiviral treatment. Sequelae have been reported in 10 to 50% of persons presenting with neurologic disease and can be severe, including permanent physical disabilities or cognitive impairment. Case fatality rates ranging from 1% to 20% have been reported. We considered factors on the patterns and distribution of disease. We noted that there is a seasonal risk, with the main risk in the warmer months from April through November when ticks are most active. Because TBE is tick-borne, large outbreaks do not occur. And there is some uncertainty in defining risk in specific locations within endemic areas, as transmission can be variable from year to year, risk areas can be very focal, and accurate data are often unavailable in real time or in some countries at all. We considered the risk factors for infection among US civilian travellers, although with only 11 cases, there were limited data to define the epidemiology. The common factors were that in all cases in which itinerary information was available, the travellers had had at least one opportunity for exposure to ticks. And all travelled during the main TBE virus transmission season in spring or summer. There was no apparent association with duration of travel, with infected persons reporting travel periods from 7 days to 2 months. Specific activities, with travellers reporting a variety of activities, including hiking, camping, fishing, and trail running. Basic demographics, with cases ranging in age from a young child to a male in his 70s. Or specific travel locations, with cases infected in various places throughout the risk area, including Europe, Russia, and China. For tick-related factors, we noted that humans must enter tick habitats and come in contact with ticks to have a risk of TBE, because unlike mosquitoes, ticks will not search out humans. Travellers do not pose a risk for TBE virus establishment in the United States, so vaccination does not have population-level benefits. Review of national TBE vaccination recommendations in endemic countries indicates that many countries do have recommendations, but their extent varies substantially. One country has a universal TBE vaccination recommendation. Some countries have recommendations for populations living in specific highly endemic or endemic areas, or only for persons at highest risk, such as those in certain outdoor occupations. And some have no TBE vaccination policy. For vaccine-related factors, the vaccine has a very good immunogenicity and safety profile, but like any vaccine, has the possibility of serious adverse events. For 2 of the 3 main TBE virus subtypes, there is likely but unproven effectiveness of the vaccine. These are the Siberian and Far Eastern subtypes, which are those that occur in the eastern part of the TBE endemic area and are the subtypes that cause more severe disease. And the TBE vaccine will cost more than $250 per dose and will be paid for out of pocket by most travellers. And there might be opportunity costs if a traveller has to consider buying TBE vaccine versus purchasing travel insurance or other vaccines with available financial resources. Noting all these factors, the work group considered whether there was any group of people who should receive the vaccine, where the benefits of receiving the vaccine would clearly outweigh the risks. There was some variability in opinion among the work group members on this question, but the following points summarise our conclusions. Firstly, even for the group of travellers to TBE endemic areas who travel during the transmission season and undertake an outdoor activity with risk of tick exposure, the risk for TBE disease is very low, with fewer than 1 TBE case diagnosed per million travellers. It would be difficult to justify a TBE vaccination recommendation for all travellers in this group. However, there is likely to be a smaller group who are at higher risk. All US traveller cases reported an itinerary in which their activities would have put them at risk of tick exposure. It follows that travellers who have the most extensive exposure to ticks will have the highest likelihood of TBE virus infection. Thirdly, although TBE is a rare disease, it can be very severe, and most travellers who get neurologic disease will require hospitalisation with a risk of sequelae and death. And finally, there is a safe and effective vaccine. Based on these considerations, the TBE vaccine recommendation that the work group would like to propose to ACIP is TBE vaccine is recommended for persons who are moving abroad or travelling to a TBE endemic area and will have extensive exposure to ticks based on their planned outdoor activities and itinerary. The work group then discussed a second component for the TBE vaccine recommendations, considering if there was an additional group for whom a shared clinical decision-making category of recommendation would be appropriate. We discussed whether there were data that suggested there were any groups where there was uncertainty in the risk-benefit considerations, or circumstances where some individuals might reasonably choose vaccination, or some providers might wish to recommend it for some travellers. We again discussed several important topics, including US traveller TBE cases and their extent of exposure to ticks, that there is a higher likelihood of a poorer medical outcome among some persons, and that there is variability in the perception and tolerance of risk among travellers. And I'll again provide brief information on each topic. Given the focus of our proposed primary TBE vaccine recommendation, we considered whether all the US traveller cases had had extensive exposure to ticks. While all US travellers reported some exposure, not all might have had what could be considered extensive exposure, although this was difficult to assess in all cases based on the amount of itinerary information available. Nonetheless, to protect all travellers going to TBE endemic locations who might have tick exposure, a very large number of doses would need to be given to prevent 1 TBE case. As I mentioned earlier, in this group we have estimated that more than 1 million travellers would need to be vaccinated to prevent 1 case. In regards to higher risk of a poorer medical outcome among some persons with TBE, older persons have consistently been shown to have poorer outcome. We also considered personal perception and tolerance of risk. For the evidence to recommendations assessment, one of the surveys we reviewed was on decision-making on vaccination for a disease that was similar to TBE, having a risk of 1 in a million but the possibility of a severe outcome, and with a vaccine that was similar to TBE vaccine, being safe and effective, having the possibility but very low probability of serious adverse events, and costing more than $250 a dose. The results indicated 1/3 of respondents were somewhat or very likely to be vaccinated, and 43% were somewhat or very unlikely to be vaccinated. The 1 in a million risk of a severe disease was a key factor in decision-making on whether to be vaccinated or not for respondents in both groups, indicating very different personal perceptions and tolerance of risk. Considering these factors, the work group's conclusions on an additional shared clinical decision-making component of the TBE vaccine recommendations were that some travellers might be exposed to ticks but will not have extensive exposure, and several factors might be considered in the risk-benefit assessment for TBE vaccination. These include that there is an extremely low risk of disease overall, but there will be heterogeneity in risk based on activities and itinerary. Some persons might have risk factors for a poorer medical outcome. And there are clear differences between individuals in their perception and tolerance of risk for a severe disease like encephalitis that could cause death or disability. Given the overall risk-benefit assessment is ill-defined for this group of travellers, but that some individuals might reasonably choose vaccination and some providers might wish to recommend it, we think a second shared clinical decision-making component for the TBE vaccination recommendations is appropriate. Therefore, we would like to propose the following recommendation. TBE vaccine might be considered for persons travelling or moving to a TBE endemic area who might engage in outdoor activities in areas ticks are likely to be found. The decision to vaccinate should be based on an assessment of their planned activities and itinerary, risk factors for a poorer medical outcome, and personal perception and tolerance of risk. I'm happy to take questions. I'll put our proposed recommendations up on the screen, and Dr. Lee, I will hand back to you.
Thank you very much, Dr. Hills. That was excellent, and thank you for being so responsive to the committee's comments from the last session. This session is now open for questions. Are there any questions from our members, ex officio or liaison members? Thank you, Dr. Long.
Thank you very much. That was so clear. I just didn't, this slide and the slide immediately preceding, it looks like you left a little sunlight between, if you go back one slide if you don't mind. You started that sentence with TB vaccine might be considered, and it sounded like the might be considered applied to the group for whom this now is, the option is going to be recommended. It's one slide before, it's before that one. Yeah, so why?
Sorry, so to clarify, the proposed recommendation heading there is the second component of our overall recommendations. So this is the proposed shared clinical decision-making recommendation. Okay. So sorry for that lack of clarity, but this is the might be considered and is our shared clinical decision-making category, with the recommended category being the recommendation that uses the recommended wording.
Thank you very much.
Thank you. Dr. Sanchez.
Thank you. No, I just want, it's just a comment. I really want to, pull up the work group because certainly this is, it's a great follow-up to our previous discussions, and I certainly agree with the recommendation and with the shared decision-making. Thank you.
Thank you, Dr. Sanchez. Dr. Kimberlin.
David Kimberlin, AAP Red Book. This is a minor question, but on the slide projected now, normally with universal recommendation, it's a should be given, and with at least my experience with shared decision, clinical decision making, it's a may be considered, and yet here it's might be considered. Is there any nuance between the word may and might here?
Thank you, Dr. Kimberlin, for that question. I believe at CDC we have tended to use might rather than may, as might implies possibility and may suggests permission, but I will definitely confer with the Secretariat for guidance and ensure that is clarified before the vote later today.
Thank you, Dr. Hills. And Dr. Kimberlin, I actually have the same question about the language, but appreciate that we can have the moment to clarify that with Secretariat before the vote. Dr. Daly.
Just a quick question, and thanks for that presentation. Just sort of how and where extensive exposure will be defined. Thank you.
Thank you for that question. If I could have slide 50, please. So the work group did discuss this, and we intend to include some text with the recommendations. And essentially for shorter duration travel, it might mean frequent exposure, such as daily, to environments that might harbour infected ticks. And for longer travel duration, so for example, a month or longer, it might mean regular exposure, such as a few times a month.
Thank you. Dr. Goldman?
Thank you. And to somewhat follow up on Dr. Kimberlin's question, because I was a little concerned about the language as well, my understanding with the Affordable Care Act that recommended vaccines must be covered by insurers. So how does the might consider versus shared clinical decision-making play into that as far as the concern for equity and access on patients being able to afford the vaccines? I know that initially there was the comment that will probably be in general medical offices, but as opposed to travel clinics. My concern is that while, for example, I do in fact have access to certain travel vaccines, yellow fever, et cetera, the volume of patients necessarily coming in for that is so low that it doesn't allow for storing the vaccines cost effectively. So I'm concerned it may lead to a difficulty in access for patients to get the vaccines, except at travel clinics as opposed to general medical offices. So I'm wondering if we can clarify that language and how that might play into insurance coverage in the Affordable Care Act. Thank you. A great presentation.
Thank you very much for that question. The Affordable Care Act relates to vaccines that are on the routine schedule, and so the travel vaccines will not be on the routine immunisation schedule, so that is not directly relevant to TBE vaccine as a travel vaccine, but thank you for asking that question to clarify that.
Thank you. Are there any additional questions or comments? I don't see any additional hands raised for the moment. So Dr. Hills, would you please return to the series of votes? There are 3 proposed recommendations for the committee to consider on the table. And I'm wondering if you would be able to read through the first proposed recommendation for a vote.
Could I please have slide 40? So the first recommendation for a vote is for laboratory workers, and the language is TBE vaccination is recommended for laboratory workers with a potential for exposure to TBE virus.
Thank you. Are there any questions or clarifications needed by committee members? Excellent. Dr. Talbot.
I was actually just hoping to move to we vote on that.
You may do so.
Okay, thank you.
So Dr. Talbot is making a motion to accept the proposed recommendation number 1 for laboratory workers for a vote. We have a motion on the table. Would anyone like to second? Ms. Bata.
Yes, I will second.
Thank you. It's been moved and seconded that we adopt the recommendation language on the slide for laboratory workers. We will return to this vote after public comment later this afternoon. So that is vote number 1. I would like to ask Dr. Hills to read the second vote up for consideration.
So the second vote is for persons who travel abroad, which, as I mentioned, has a recommended and a shared clinical decision-making component, and there will be separate votes for each of those components. So our recommended component, TBE vaccine, is recommended for persons who are moving abroad or travelling to a TBE endemic area and will have extensive exposure to ticks based on their planned outdoor activities and itinerary.
Thank you. Would any of our voting members like to make a motion for this second vote? Dr. Sanchez.
Yes, I move to approve that language and vote.
Thank you, Dr. Sanchez. And Dr. Alt, would you like to second the motion?
I will second the motion.
Thank you. It's been moved and seconded that we adopt the recommendation language on the slide for vote number 2. For persons who travel abroad, the TBE vaccine is recommended for persons who are moving abroad or traveling to a TB endemic area and will have extensive exposure to ticks based on their planned outdoor activities and itinerary. And again, we will return to this vote after public comment later this afternoon. There is a third vote on the table. Before I move on, I just want to confirm, Dr. Long, did you have any clarifying questions at this moment?
Yes, I did. I didn't think you asked for any recommendations to change anything, and moving abroad doesn't work, I don't think. Abroad is a long place, a large place. You could be going to Africa. I don't know where abroad is, but anyhow, it's across an ocean. So I would move to delete the word abroad. So people who are moving or traveling to an endemic area, I think is what we're talking about.
Thank you for that clarification. I think we will take that under consideration. I'll ask Dr. Hills if that wording can be reconsidered. Are there any objections to changing that wording? Okay. We will let the motion stand as is with the suggestion by Dr. Long to amend the language slightly for clarity, but the vote itself stands. So we will move on. Thank you, Dr. Long. We'll move on to the third proposed vote. Dr. Hills, would you please be willing to consider this? And we will also take into consideration with the Secretariat the language around might versus may, but please go ahead and read it as is.
So TBE vaccine might be considered for persons travelling or moving to a TBE endemic area who might engage in outdoor activities in areas ticks are likely to be found. The decision to vaccinate should be based on an assessment of their planned activities and itinerary, risk factors for a poorer medical outcome, and personal perception and tolerance of risk.
Any comments or clarifications of the wording on this third proposed vote? Dr. Long.
Yes, in the laying out of this, there was an asterisk and something below that said something that I thought ought to be in it, and it's now not in it. I assume it's assumed, and that is depending on activity, so of the ticks and the virus. So you might have a hyper endemic something going on where this would be very important. So I assume there are other considerations that are in this language. And I did see it. I had a question about it. I did see it in an aside, and I wonder if it needs to be put in the language of the recommendation.
Could I have slide 53, please? So perhaps it would help for me to show the language that will accompany the recommendations, because I think it's an important point you're making, Dr. Long, that there perhaps needs to be some additional language around the specific recommendation. So we will have in the recommendations with the additional text this information here that says that the risk for TBE for most US travellers to TBE endemic areas is very low. However, some persons who travel abroad are at increased risk for infection based on their season and location of travel and activities. The main TBE virus transmission season is during the warmer months from April through November. Ticks are typically found in woodland habitats, including in deciduous forests and on the edges of forests in the transition zone between forests and grasslands. Persons planning to undertake recreational outdoor activities, for example, hiking, camping, cycling, hunting, fishing, bird watching, or collecting mushrooms or berries, or who might be occupationally exposed, for example, forestry workers, farmers, military personnel, might come into contact with infected ticks. And then if I could have slide 56, please. We'll have two additional paragraphs, one that points out that all persons who travel abroad to TBE endemic areas should be advised to take precautions to avoid tick bites, and list the preventive measures for that. And then a final paragraph that talks about further that TBE vaccine can further reduce the risk for infection in addition to using those tick prevention measures, and might be indicated for some persons, and lists some considerations there. And then in addition, we intend to provide this box here that outlines factors that increase risk for tick-borne encephalitis among persons who travel abroad, that outline specifically factors related to season, location, activities and occupations, duration, and other considerations. To go to specifically to your point about location, with that second bullet there under location, we will have on the CDC website brief information on countries with TBE risk areas to help providers with understanding where that risk might be. We are going to clarify that it needs to be interpreted with caution, because information is not available in some cases at all. It's often not available in any timely way, but this information is the best that we can provide to help guide healthcare providers who are trying to think about moving to risk areas. The one fortunate thing we do have in terms of it being a tick-borne disease is that there is no large outbreaks like that can occur with mosquito-borne infections, where you really can have very rapidly evolving and large outbreaks, but tick-borne diseases don't behave in that same manner.
That's very, very helpful. And I assume that this link would, if there was knowledge of some hyper-endemic something going on, it would, and it was known that it would be there. So they're mainly, you mainly say negative things here about what you don't know, and I understand that. But if you did know, presumably it would be there.
Yes, thank you, Dr. Long. That's an important point. If we were aware of a particular concern, we would make sure that there was information provided, and we will probably work with the Division of Global Migration and Quarantine to post a notice to alert travellers.
And is it the group's opinion then that you don't need a general statement about that, which is it is the activity of the virus and the tick and the density of the virus and the tick? You don't need that at all in the May consideration? You have all these other things there.
Yeah,
maybe we should look at that again.
Thank you. Maybe if we can have slide 40 back with the recommendations. So one other thing that I think is important is that in terms of the language, the decision to vaccinate should be based on assessment of their planned activities and itinerary. With itinerary there, we're trying to capture that piece that I think you're talking about in terms of, where they're going, if it might be some area where there's a concern, with rurality of where they're going, with the season that they're going, if it's midsummer as compared to, moving into the winter period, and also their duration of travel. We just did discuss that and thought that probably it wasn't, we were trying to keep the language as succinct as possible in this actual recommendation. So, one option would be to put those examples in there, for example, location, rurality, season, duration, but there will be that additional language surrounding the recommendations to help clarify that.
Thank you. If that's clear to the practitioners on the call, I'm fine with it.
Thank you, Dr. Long. I wanted to give Dr. Paling perhaps a moment to comment since she is chairing the work group and to provide her opinion on what the best way forward would be. Dr. Paling?
Oops, I'm sorry. All right. Thank you for this great discussion. The work group actually had extensive conversations on this and figuring out how best to word the recommendation. And our assessment was that we liked this wording to focus on the planned activities and itinerary and highlighting the main components and leaving the rest in the clinical considerations, and really like the box to draw people's attention. We would welcome feedback and other thoughts on this matter. Thank you.
Thank you, Dr. Paling, Dr. Hills, and Dr. Long. I think in general, we try and keep the recommendations succinct and allow for the detail to be provided in the clinical considerations. As long as it does not change the intent of the recommendation, I think that would be the main question to focus on here. Dr. Long, are you comfortable with the wording as is with the intent of the clinical considerations capturing the detailed information?
Yes, and considering what Dr. Paling has said and seeing that there are no hands from the practitioners on this call who would never think about looking to see if there happens to be hyperendemic transmission right now, for instance, in a person who's going.
Thank you. Okay, thank you, Dr. Long, for that clarification. We always appreciate your editorial eye. Well, let us move to, let me ask if any of our voting members would like to make a motion on this third vote on the table. Ms. Bata?
Yes, I move that we adopt this third vote language or recommendation.
Thank you so much. And to clarify, we will clarify whether might or may is the wording to be used during the final version of the vote language later this afternoon. We have a motion on the table. I'm looking for a second. Dr. Daly.
I second the motion on the table to accept the language here. Thanks.
Thank you, Dr. Daly. So it's been moved and seconded that we adopt the recommendation language on the slide with the additional clarifications noted. We will return to the vote after public comment later this afternoon. So are there any other questions, comments from our members, our ex officio members, or our liaison organizations? Okay, I don't see any additional hands raised. We can come back to it later this afternoon. If there are additional comments or questions that arise, please feel free to raise it prior to the vote. With that, thank you very much, Dr. Hills and Dr. Paling, for, again, for being so responsive to the committee's comments from the last session and for making the recommendations much more clear for the practitioner to implement. We would like to move on to the cholera session. And we are slightly ahead of schedule, but I will be glad that we are running on time and, hopefully we can leave a little bit of extra time at the end. So we'll move on to Dr. Sanchez, Chair of the Cholera Vaccine Work Group, who will provide an overview of today's session. Dr. Sanchez, I can't hear you yet, so the floor is yours.
Thank you. Next slide. Today will be the introduction to the cholera vaccine. Next slide. So I just want to acknowledge the cholera vaccine work group members and contributors, my co-ACIP member, Matt Daly, ex-officio members, ACIP liaisons, the technical advisors, as well as CDC contributors, but really highlight and really thank our remarkable CDC lead, Jen Collins, who will be presenting today. Next slide. So the policy topic under consideration that for which there will be a vote this afternoon, should ACIP recommend CVD 103 HGR for children and adolescents aged 2 to 17 years traveling to an area with active cholera transmission. Next slide. So the background for the work group, in June of 2016, ACIP recommended the cholera vaccine for adult travelers aged 18 to 64 years from the United States to an area with active cholera transmission. In December 2020, FDA extended the approved usage to include children and adolescents aged 2 to 17 years of age. In February 2021, the work group presented background information and the manufacturer presented pediatric clinical trial data. And then in January of 2022, the work group presented evidence to recommendation framework and the manufacturer presented data on pediatric dose development, including the addition of sweeteners. Next slide. So today's agenda will be the presentation of evidence to recommendation summary, considerations for use, and proposed policy option for the cholera vaccine among children and adolescents aged 2 to 17 years of age will be presented by our CDC lead, Jen Collins. Thank you.
Thank you, Dr. Sanchez. And we'll move on to Dr. Jennifer Collins from CDC. Please go ahead.
Good morning. Next slide. So today I will begin with the summary of the work group's January 12th ACIP meeting presentation, including the policy question and evidence to recommendation summary. Then I will discuss considerations for prevention of cholera and use of CVD 103 HGR, including responses to ACIP members' questions from January 12th. Finally, I will present the proposed policy recommendation for discussion. Next slide. The current policy question under consideration is, should ACIP recommend CVD 103 HGR for children and adolescents aged 2 through 17 years traveling to an area with active cholera transmission? The PICO components are shown in this slide. Because CVD 103 HGR is the only cholera vaccine licensed for use in the United States, the comparison group was no cholera vaccine. Next slide. A summary of the evidence to recommendation framework presented on January 12th is shown here. The work group felt that cholera is probably a public health problem among children and adolescents aged 2 through 17 years traveling to an area with active cholera transmission. The work group determined the desirable anticipated effects were moderate, the undesirable anticipated effects were small, and that the balance of benefits and harms favors CVD 103 HGR, with low overall certainty for the critical outcomes. The workgroup determined CVD 103-HGR is acceptable to key stakeholders, that the effect on equity varies, and that it is probably feasible to implement among children and adolescents aged 2 through 17 years traveling to an area with active cholera transmission. The workgroup determinations for values and resource use were don't know. Next slide. The workgroup consensus was that desirable consequences probably outweigh undesirable consequences in most settings, given that we only had indirect data to assess the desirable consequences. Next slide. The workgroup consensus was that we recommend the intervention, CVD 103-HGR, for children and adolescents aged 2 through 17 years traveling to an area with active cholera transmission. Next slide. Now I will discuss considerations for prevention of cholera and use of CVD 103-HGR. Next slide. CDC's Travelers Health Branch updates the list of countries with active cholera transmission on a monthly basis on the web pages shown to the right. As of January of this year, the 15 countries listed in the purple box are considered to have active cholera transmission. The destination pages shown on the lower link specify whether cholera transmission is localized to certain areas or widespread. Next slide. Regardless of cholera vaccination status, travelers to cholera-affected areas should use personal protective measures. That is, they should consume safe food and water, wash hands often with soap and safe water, and follow recommended sanitation practices, including using latrines or burying stool. More detailed prevention information is available on the websites shown on the slide. Next slide. CVD 103-HGR is the only cholera vaccine licensed for use in the United States. It is a single-dose, live attenuated oral vaccine derived from Vibrio cholerae 01. Production has been temporarily discontinued during the COVID-19 pandemic, but the manufacturer has specified it will be available again beginning May 1st of this year. Next slide. Regarding Dr. Brooks' question in January about the number of doses administered, the manufacturer provided data indicating that 62,179 doses were sold in the United States during 2016 through 2019. We don't have data on how many of those were administered. Notably, although production began in 2016, ACIP approval for adults did not occur until June of 2016. The initial authorization also required that the vaccine be stored frozen. Next slide. Regarding administration setting, the workgroup feels CVD 103-HGR may be optimally administered in a travel clinic, given the relatively complicated dose preparation and administration. However, as ACIP members noted during the January 12th meeting, many travel clinics have closed during the pandemic, and whether they will reopen is uncertain. The workgroup agrees that administration in non-travel clinics is permissible. Regardless of whether it is a travel clinic, CVD 103-HGR should be prepared and consumed in the medical office to minimize potential dosing errors, and providers should carefully follow instructions in the package insert. I will review some of this information in the coming slides. Next slide. The buffer component and active component packets should be stored refrigerated at 36 to 46 degrees Fahrenheit. Packets should not be out of refrigeration for more than 12 hours before reconstitution, and they should not be exposed to temperatures exceeding 80 degrees Fahrenheit. They should also be protected from light and moisture. Next slide. Regarding administration of CVD 103-HGR, recipients should avoid consuming food or drinks for 60 minutes before and after vaccine administration. Next slide. Only cold or room temperature, purified, bottled, or spring water should be used to reconstitute the buffer. Tap water contains chlorine that can affect the viability of orally ingested live attenuated bacterial vaccines. Next slide. Detailed preparation and reconstitution instructions are available in the package insert, as shown in the images to the right. First, the buffer is mixed with 100 milliliters of cold or room temperature purified bottled or spring water. As shown in step 5, the buffer solution should be mixed with a disposable stirrer until it completely dissolves. For children aged less than 6 years, half of this reconstituted buffer solution should then be discarded. That is, after the buffer sachet is mixed with water. The active component packet is then added and again stirred until it disperses to form a slightly cloudy suspension that may contain white particles. If the packets are reconstituted in the improper order, the vaccine must be discarded. The prepared vaccine must be consumed within 15 minutes. Next slide. Administration of CVD-103-HDR with sweeteners is not currently covered in the package insert. As noted on January 12th, the manufacturer anticipates a supplemental filing with FDA early this year. Unpublished data presented by the manufacturer in January of 2020 demonstrate CVD-103-HDR is not compatible when mixed with medicine flavorings that contain propylene glycol or when mixed with food and drinks, such as rice cereal, applesauce, juice, or milk. Data presented support that the vaccine is compatible when mixed with 1 to 4 grams of sucrose or table sugar or 1 gram of stevia sweetener. 93% of vaccine recipients aged 2 through 17 years in the clinical trial consumed the vaccine with Pure Via brand stevia. Next slide. Providers should also advise recipients about the most common side effects within 7 days of CVD-103-HDR, including fatigue, headache, abdominal pain, nausea or vomiting, lack of appetite, and diarrhea. These adverse reactions were most commonly rated as mild in the clinical trials. Next slide. No clinical trials have evaluated the safety or efficacy of booster doses of CVD-103-HDR in preventing cholera. The duration of protection beyond the 3-month period evaluated in adults aged 18 through 45 years is unknown. The serum vibricidal antibody assay used in the pediatric clinical trials is likely a surrogate for protection mediated by the intestinal mucosa. Next slide. We will now discuss co-administration of other medicines or vaccines. Next slide. Antibiotics might have activity against the vaccine strain. Therefore, CVD-103-HDR should be administered at least 14 days after completion of antibiotics, either oral or IV antibiotics. A shorter duration may be acceptable if travel cannot be avoided, but may diminish the effectiveness of the vaccine. Next slide. The optimal duration between completion of CVD-103-HDR and starting antibiotics is unknown. In certain circumstances, antibiotics may be clinically necessary after the vaccine, such as to treat an unrelated infection. Nearly all vaccine recipients in clinical trials had seroconversion by 10 days, suggesting administration of antibiotics after this may not affect protection. Next slide. Chloroquine may diminish the immune response to CVD-103-HDR. Therefore, CVD-103-HDR should be administered at least 10 days before starting chloroquine, such as for malaria prophylaxis. Next slide. No data are available on concomitant administration with other vaccines. Enteric-coated live attenuated typhoid vaccine, TY21A, is another common oral travel vaccine. Experts suggest taking the first dose of TY21A at least 8 hours after CVD-103-HDR. This might decrease potential interference of the buffer of CVD-103-HDR with the TY21A vaccine. Next slide. Now to contraindications and precautions. Next slide. CVD-103-HDR is not licensed for children aged less than 2 years or adults aged more than 65 years. And no data exists about the safety and effectiveness of the vaccine in these populations. Next slide. CVD-103-HGR should not be administered to persons with a history of severe allergic reaction, such as anaphylaxis, to any component of this vaccine or to a prior dose of any cholera vaccine. Next slide. No data are available regarding the current formulation of CVD-103-HGR during pregnancy or breastfeeding. Pregnant women are at increased risk for poor outcomes from cholera infection. Pregnant women and their clinicians should consider the risks associated with traveling to areas with active cholera transmission. The vaccine is not absorbed systemically. Therefore, maternal exposure to the vaccine is not expected to result in exposure to the fetus or breastfed infant. However, the vaccine strain might be shed in stool for at least 7 days after vaccination, and theoretically, the vaccine strain could be transmitted to an infant during vaginal delivery. Next slide. No data are available regarding the current formulation of CVD-103-HGR in persons with altered immunocompetence. Persons with altered immunocompetence and their clinicians should consider the risks associated with traveling to areas with active cholera transmission. Consultation with a specialist in infectious diseases or immunology should be considered if travel to an area with active cholera transmission is necessary. ACIP generally advises against administering live vaccines to persons with most forms of altered immunocompetence. Next slide. CVD-103-HGR may be shed in the stool of recipients for at least 7 days. Patients should be counseled that the vaccine strain can potentially be transmitted to non-vaccinated close contacts, such as household contacts, and to wash their hands thoroughly after using the bathroom and before preparing or handling food for at least 14 days after vaccination. Next slide. Now to the policy option for discussion. The proposed draft recommendation developed by the work group is lyophilized CVD-103-HGR is recommended for children and adolescents aged 2 through 17 years traveling from the United States to an area with active cholera transmission. Next slide. I would like to thank the members of the work group and other contributors to the content included in this presentation. Next slide. Thank you, and I'm happy to take any questions.
Thank you very much, Dr. Collins. This presentation is now open for questions. Dr. Paling.
Thank you, Dr. Collins, for this great presentation. I wanted to follow up on a point that you made and ask a clarifying question. For many vaccines, oral vaccines, we pay attention to the family members, and if there are persons with serious immunocompromising conditions, consider holding the oral vaccine. Is that a consideration here for the cholera vaccine? Thank you.
Thank you, Dr. Paling. So the package insert does note that providers should consider whether to administer the vaccine if the recipient has an immunocompromised household or other close contact. However, we discussed this in the work group and felt that that language was a little bit strong. If I could have Chris go to slide 60, please. So in a small study of the preliminary formulation of this formulation, there was no household transmission of CVD-103-HGR. So in the study, they had 66 healthy adults who were randomized 5-to-1 to vaccine or placebo. And stool shedding did occur in 11% of vaccine recipients. Then they also enrolled 24 household contacts of vaccine recipients. None had the vaccine strain isolated from stool on a day 7 specimen, and none had vibrocidal seroconversion on a day 28 specimen. I think it, may depend on the individual, and providers may want to counsel people if they don't think or they don't have access to sort of adequate hygiene and sanitation measures. But I think most people in the United States do, and with kind of adequate hand washing and sanitation, the work group didn't really feel like the risk posed to household contacts of acquiring it was substantial enough to say to not do it. Also noting that that vaccine has been attenuated.
Thank you. Dr. Lair.
Yes, thank you. Could you please go to slide 19? You mentioned that the duration of protection is unknown, but in the background information that came with the slides yesterday, there's this study of long-term immunogenicity that came out in 2021 that said that there's still, I think, 65% of people had seroprotection at 2 years. I just wonder if you could comment on that. Do we trust the seroprotection data, or are you just saying that there's no randomized controlled data with actual disease?
Thanks for that question. And actually, Chris, if you could go to slide 63. And yeah, so essentially there are no long-term efficacy data where an oral challenge study has been done, which would really be the gold standard to determine whether the vaccine is still effective that far out. These are data that the manufacturer shared during the February 2021 presentation, and they're published in the study that you're referencing. We do see from those data that the seroconversion rates and GMT levels remain somewhat high, up to 2 years out, but really the issue is that we don't know how good of a marker of long-term protection serum vibrocidal antibodies are, and my understanding is they're not even maybe the best marker of long-term protection. So they are sort of what's the best available measure and best accepted measure to use in clinical trials where we're not directly assessing efficacy. They're the best immunologic parameter that we have, but they're not, they're mostly a surrogate, not likely mechanistic. They are sort of a marker of complement-mediated bactericidal activity that doesn't really account for why they would explain the protection that is thought to be mediated by an immune response at the intestinal mucosa. So these data are, encouraging in some ways, but without an oral challenge study that far out, I think that the experts in the field would not necessarily trust them to say that the vaccine is protective that far out.
Thank you.
Thank you. Are there any additional questions from ACIP members or liaison members? Dr. Long.
Yes, a very minor point on one of your slides, you about recommending hand washing for a certain number of days after vaccination, after using the toilet, inferring that you don't recommend hand washing any other time after these activities. So it would be good if you could say hand washing is always recommended after using the toilet. And I would add diaper changes, since some 2-year-olds are still in diapers, with special care or assiduousness or something during the 10-day, or I can't even remember if it was 10 days or 14 days, the period of shedding vaccine bacteria. Thank you.
Thank you, Dr. Long. As someone who has done infection control, I very much appreciate your comments and agree. Dr. Kimberlin.
David Kimberlin, AAP Red Book. One of your slides, slide 28, I believe, at least in the slide set that was distributed by PDF, is about pregnancy. And the final bullet about shedding in stool for more than 7 days after vaccination, theoretically, therefore, an infant could be exposed during vaginal delivery. Was there any consideration by the work group or, kind of interfaces with ACOG as to whether a limitation should be made where it's not given to a pregnant woman beyond, 38 weeks, 36 weeks, something like that, to try to minimize that likelihood?
Dr. Collins, I'll hand it over to you first, and then I don't know if there's any members of the work group that represent ACOG that could make a comment on that.
Yeah, sure. I'll say we did not directly discuss that. Our work group was mainly focused on children and adolescents aged 2 through 17 years, and of course, adolescents can become pregnant. This language is from the kind of previous adult MMWR, but would welcome the input of ACOG.
Dr. Ecker, are you on? Or perhaps I'll call on Dr. Sanchez. And, I don't know if there is a comment that you can actually make, but if there's any considerations you would like the work group to consider or the committee to consider. Dr. Sanchez, actually, let me call on Dr. Alt first. Dr. Alt, please go ahead.
Well, I think we discussed this before when we talked about adults, and, the best advice would be not to go to the area. So, I think it also came up when there were CDC workers going to Haiti a few years ago, and I don't remember what we decided in detail, but I don't have any problems with the way it's worded right now. Of course, we'll get experience with these vaccines as they get used in pregnancy more and more often.
Okay, thank you, Dr. Alt. Yes, the comment about aligning with the adult recommendations makes sense. So perhaps we can look back and come back to it after a break. Dr. Sanchez.
Thank you, David, for that comment. We didn't really, and that's a good point. We didn't specifically comment about not giving it in the previous 7 days, 7 to 14 days before planned delivery. I think we also have to ascertain the risk versus benefits of such. And if that woman is going to be exposed during that time, it may be better that she does receive it rather than not. So I think that there's some risk benefit that needs to go into the equation. The other thing is that it is an attenuated strain that, but I think that is, something to be considered. So I thank you for bringing that up.
Thank you, Dr. Sanchez. Any other questions or comments?
This is Jen Collins. I was just going to say, I was looking at the ACOG statement on just travel in general during pregnancy. So that might be something we can also consider. Their statement says most commercial airlines allow pregnant women to fly up to 36 weeks of gestation, and that some restrict pregnant women from international travel or from international flights earlier in gestation, and some require documentation of gestational age. So I think your question, Dr. Kimberlin, does sort of get to whether pregnant women will be traveling at that point as well.
Thank you. Dr. Sanchez, did you have any additional comments? I see your hand is raised.
No, sorry.
Thank you. Okay, Dr. Collins, would you please be willing to go back to the slide with the proposed recommendation for the committee to consider? And if you're able to read that to us, that would be terrific.
Sure. The proposed draft recommendation is lyophilized CBD 103-HGR is recommended for children and adolescents aged 2 through 17 years traveling from the United States to an area with active cholera transmission.
Thank you. I'm going to ask, I didn't see any additional hands raised. Are there any questions or comments about the wording? Dr. Long.
Yeah, I was expecting in here to see recommended for children with no contraindicating underlying immune deficiencies. I mean, you would not give this to a lot of children, or not a lot, but some children who had significant immune deficiency. And I know that in our tables in the Red Book previously, David can look right at them and see we certainly had this vaccine, attenuated live bacterial vaccines, as contraindicated in certain groups. So this would not be all children. So I don't know what the work group thought if they needed, I'm sure you didn't consider giving, well, maybe I should ask, did you consider giving this to children with underlying immunologic problems?
Dr. Collins, why don't you go ahead and answer that question, and maybe I'll turn to Dr. Wharton to just provide us with consistency in the language of the recommendations and what's included versus what's in the clinical consideration. So, Dr. Collins?
Yeah, we did discuss, and there is really just a lack of data in immunocompromised children and adolescents upon which to make a decision. I think the work group members shared your concern about providing it to children who are immunocompromised, particularly with severe immunocompromising conditions. Some of the rationale behind the language was for clarity to sort of harmonize it with the language for adults, and for adults aged 18 through 64, it's sort of a straightforward recommendation, and then the stipulation about persons with immunocompromising conditions is in the guidance, but certainly welcome further discussion about that if you think that's not the correct approach.
Dr. Sanchez, did you want to comment on that?
Yes, no, thank you. No, we did discuss it, and actually slide 29 talks about the fact that there are no data in persons with altered immune competence, but we were more of the opinion that some of these would be taken up in the clinical considerations as to any potential precautions against the use of the vaccine in such children and adolescents.
Thank you. And Dr. Wharton, did you want to add anything?
Well, I would just add that for many vaccines, we have contraindications and precautions, and those are not necessarily included in the recommendation statement. Those are additional clinical information that accompanies the recommendation statement. So, to the extent that that there should be consideration of not vaccinating certain children, it seems like we would not address it in this language here, but it would be included in additional clinical information accompanying the recommendation.
Thank you. Dr. Paling.
Hi, this is Kathy Paling. I've got a minor editorial suggestion. And my suggestion is to remove from the United States because I don't think it adds anything. And people who are going on a circuitous route and going to an active cholera transmission area is, I think, the intent. Thank you.
Thank you, Dr. Paling. Dr. Sanchez and Dr. Collins, does that seem reasonable to delete from the United States?
That seems fine with me.
Okay, that's fine as well.
Okay.
Getting it in the United States before travel.
Okay, thank you. Okay, are there any other questions or comments? Would any of our voting members like to make a motion that the recommendation state lyophilized CBD 103 HCR is recommended for children and adolescents aged 2 to 17 years to an area with active cholera transmission? Thank you, Dr. Paling.
Yes, Kathy Paling, I'd like to make a motion to accept the draft with the addition of the editorial suggestion. Thank you.
Thank you. We have a motion on the table, and would anyone like to second? Dr. Daly?
Yeah, I'd second that we accept the language after striking from the United States. Thank you.
Thank you. It's been moved and seconded that we adopt the recommendation language with the proposed amendment on the slide that will be edited for the final vote. We will return to the vote after public comment later this afternoon. And again, if you have additional questions or comments later this afternoon, we're welcome to open up discussion again briefly before the vote. And with that, I believe we are at the end of this session. So I want to thank our morning presenters, Drs. Kaling, Hill, Sanchez, and Collins, for an excellent set of presentations and also for providing really thoughtful and extensive background materials to help support decision-making. We will plan to take a break and we will stay on time. So we will plan to meet, Dr. Wharton, just confirming, you would like us to meet at 10 minutes after the hour?
Yes, we will reconvene then.
Okay. You'll have a long break, so we'll meet again at 10 minutes after the hour, and we'll look forward to reconvening with the influenza session. Thanks, everyone.